You deserve the pain truth, because the hardest pain to endure is an unexplained one. This program will not promise you any magic cures or quick fixes. You deserve the truth and straightforward answers to the following questions. What is pain and why am I feeling it? Why is it still there after so long? And most importantly, what can I do about it to move forward with my life? Welcome to this short presentation. My name is Baram Jam, and I'm so happy that you're here on this journey with me. First of all, let's stop the futile war on pain. Before I discuss my views on the current war on pain, let's look at the success we've had with the war on drugs. In 1971, the war on drugs was a global campaign led by US government with the goal of eradicating the distribution and the use of illegal drugs. It started with Nixon and then continued with Reagan. The Drug Policy Alliance, which advocates for the end of the war on drugs, estimates that the United States is spending $50 billion annually on the war, which after 50 years, it accumulates to about $1 trillion, which is just unfathomable amount of money. And of the $1 trillion budget, 53% was for enforcement, as you can see in the image, 29% for treatment, and 18% for prevention, which included campaigns to teenagers and school kids. The Global Commission on Drug Policy released a critical report on the war on drugs, declaring the global war on drugs has failed, with devastating consequences for individuals and societies around the world. 50 years after the initiation of the war on drugs, fundamental reforms in national and global drug control policies are urgently needed. This is numerous drug policy amongst the world leaders. For example, this one was based from Geneva, Switzerland. The fact is that drug addiction is complex and multifactorial. The idea that a war focusing on quick fixes such as arresting, punishing, and incarcerating people could eradicate drug addiction is to say the least futile and short-sighted. There are now numerous papers on how the war on drugs has failed miserably. Guess what? Drugs have won. So let's now discuss the war on pain. The fact is that chronic pain is also quite complex and multifactorial. The evidence overwhelmingly shows that a war focusing on quick fixes or eliminating it is also futile and short-sighted. Here are some examples of quick fixes. Painkillers, over-the-counter and prescribed. Creams and rubs. There's numerous of them. Hot packs and hot patches. So many of them. Tingling machines. Various gadgets with lights, sounds, and pricks. And various manual therapies. And various injections. And, if necessary, various surgeries. And for the sake of this presentation and simplicity, let's call all of these, as you can see in the image below, quick fixes. And billions of dollars is spent on these quick fixes. The aim of this presentation is not to disprove the effectiveness of any of these quick fixes. Based on the specific condition, there's certainly a role for the use of any of these quick fixes. For example, there's substantial evidence to support the use of various pharmaceutical interventions after an acute trauma, post-surgery, or for pain associated with conditions ranging from rheumatoid arthritis to cancer. Let's make something clear. This presentation is not about pain management for medical conditions such as infections, kidney stones, fractures, polymyalgia rheumatica, cancer, or numerous medical conditions. I'm only here to discuss potential solutions for the current shortcomings in the medical management of the complex condition referred to as persistent musculoskeletal pain, commonly just referred to as chronic pain. When it comes to persistent musculoskeletal pain, despite the abundant use of a variety of painkillers and anti-inflammatory drugs, a substantial number of patients don't attain adequate symptomatic relief, and there are numerous studies to support that. When it comes to persistent pain, the evidence, in fact, doesn't support the use of any of these quick fixes. On the contrary, these passive interventions may be contributing to the maintenance of pain. In 1995, the American Pain Society urged healthcare providers to treat pain as the fifth vital sign, highlighting the essential need for improved pain care. And the vital signs include the first one is body temperature, second is pulse, third is respiratory rate, fourth is blood pressure, and the fifth one that they added was a pain scale to evaluate people's pain from 0 to 10. In an effort to improve pain care, pain-related questions were also added to patient satisfaction surveys for those with both acute and chronic pain, where at the end of their stay at the hospital or the clinic, they'd ask them, how satisfied were you with your pain care at this hospital? Sadly, after 20 years of research, a large body of evidence indicates that measuring pain intensity using tools like the Numeric Pain Rating Scale, or NRS, hasn't improved pain outcomes. NRS scores shouldn't be used in isolation to determine whether additional analgesic treatment is needed, as it had adverse side effects. The fifth vital sign, how treating pain contributed to the opioid epidemic. While the initiative was associated with increased patient satisfaction, it also led to an increase in opioid-related adverse drug reactions. These findings emphasize the danger of allowing patient satisfaction surveys to influence pain management decisions. Who knew that patients would be more satisfied the more pain medications you'd give them? In 2016, American Medical Association finally voted to stop treating pain as the fifth vital sign because they believed it was one of the contributing factors to the opioid crisis. Therefore, they eliminated pain management questions from patient satisfaction surveys in hospital. Again, the fact is that chronic pain is complex and multifactorial, and the idea that a war focusing on eliminating it using quick fixes is, to say the least, short-sighted. For instance, people who live in more deprived neighborhoods with low levels of education and perceived income inequalities are more likely to experience chronic pain. And exactly what kind of a quick fix is going to help them? Regrettably, the cycle of socioeconomic deprivation and chronic pain is exacerbated by the associated disability and potential lack of meaningful employment. Again, exactly what kind of war involving a quick fix is going to help them? A survey study showed that those who self-identified as Black, Asian, or mixed ethnicity were more likely to report chronic pain than those identifying as white. However, once adjusted for income, employment, and adverse life events, the association between self-reported ethnicity and chronic pain was attenuated. Again, skin color was irrelevant, ethnicity was irrelevant if all other factors were equal. But again, exactly what kind of a war involving painkillers, injections, manual therapy is going to fix this racial disparity? Work stress, job dissatisfaction, and lack of work autonomy have all been found to be independent predictors of chronic pain. So will a war focusing on a quick fix help them? Tobacco addiction and alcohol dependence have been associated with chronic pain and greater pain intensity. So will a war focusing on quick fix help them? A nutritionally deficient diet and lack of vitamin D have been associated with chronic pain. Again, what kind of a war involving painkillers, hot patches, or tingling machines is going to possibly address this issue? Anxiety, depression, hopelessness, and fear avoidance behaviors are all related not only to developing chronic pain, but also to having worse outcomes from chronic pain. So, will a war focusing on a quick fix help address these mental health and psychological issues? Chronic post-surgical pain affects up to 10% of patients, with a higher prevalence in those who experience anxiety with their operation and those who develop post-operative infections. So will a war focusing on a quick fix help them? Obesity is associated with chronic pain, perhaps due to the greater low-grade inflammation associated with physical inactivity and high BMI. There is, however, little evidence that weight loss improves chronic pain. Again, what kind of a war involving painkillers or manual therapies is going to address inactivity and the associated high BMI? Poor sleep and sleep apnea are associated with the development and greater intensity of chronic pain. So what kind of a war focusing on a quick fix is going to address insomnia? Passive coping strategies such as resting and taking medications is associated with double the level of disability from pain in comparison with those who adopted active strategies such as exercise. Could a war involving passive strategies such as medications, gadgets, or manual therapies be making things, in fact, worse? People who have been involved in violent or abusive relationships or with PTSD are more likely to experience chronic pain. So, will a war focusing on a quick fix help those who have post-traumatic stress disorder? Sadly, traumatic adverse childhood experiences, also referred to as ACEs, are strongly associated with the development of chronic pain. How can a war focusing on a quick fix possibly be a solution to this complex experience? Offspring of parents with chronic pain have been shown to be at a significant greater risk of developing chronic pain, with poorer outcomes. So, how can a war focusing on a quick fix possibly be a solution to chronic pain? Let's make something clear. In the past number of decades, the medical system has done a remarkable job in pain management for those post-surgery, acute trauma, rheumatological, or with cancer-related pain. Also, thanks to advances in lab work and medical imaging technology, serious pathologies and illnesses can be detected earlier and better managed than ever before in the history of medicine. However, to date, the medical management of chronic non-cancer pain hasn't been shown to be effective, as the prevalence of chronic pain and disability continues to rise. The Global Burden of Disease Study has reported that despite the billions of dollars spent on interventions, there are almost 2 billion people worldwide still coping with some form of chronic pain, and the disabilities associated with this condition is consistently increasing. When it comes to the management of chronic pain in the past number of decades, the primary focus has been to eliminate or to at least reduce it using medical interventions such as anti-inflammatories, analgesics, opioids, various injection therapies, and even surgeries. Pain elimination is also often the primary focus of physical therapy, chiropractic, massage therapy, and acupuncture treatments. And of course, with the intentions of finding the exact cause of musculoskeletal pain, the use of medical imaging such as X-ray, ultrasound, MRI, and CT scans have also increased. Inevitably, the medical costs associated with diagnosing, treating chronic and acute pain has exponentially increased. One could assume that with the amazing technological advances in diagnosis and with the exponential growth in various medical and therapeutic interventions, we would have somewhat reduced the prevalence of chronic pain. Wrong. There is a revolving door of consulting several healthcare providers in order to be fixed, leading to patient frustration, confusion, hopelessness, and anxiety. Not only have we not reduced the prevalence of chronic pain and its associated disability, the rate has been consistently rising with each passing decade. So, what's going on? It's time for the medical system to adopt modern paradigms, as when it comes to the war against chronic pain, we're all losing badly. I look forward to seeing you at the next lesson where I shall discuss these new modern paradigms.